Welcome to Understanding Precordial Transitions. I'm Dr. Jerry W. Jones with Medicus of Houston. Now, just take a moment to think about it. How much do you really understand about precordial transition? What is its significance? What does it measure? What is it telling us? When is it appropriate to refer to it, or to note it, or to include it in a description? What does it mean? Let's talk a little bit about the mean QRS axis. The mean QRS axis refers only to the frontal plane. For the horizontal plane, we don't refer to axis. We refer to rotation. We measure rotation by the location of the precordial transition. The QRS axis in the horizontal plane can be calculated, but it's a lot more complicated. We used to do this years ago, and then we decided that rotation was much easier and more effective to use. Now, the leads are not separated by the same number of degrees in the horizontal plane as they are in the frontal plane. You recall in the frontal plane, if you're looking at the hexaxial reference grid, all leads are 30 degrees apart. That's not the case with the horizontal plane, which makes it a bit more difficult if you're actually trying to calculate the mean QRS axis specifically in degrees. Rotation is much easier and can usually tell us exactly what we want to know. Precordial transition has many uses, but with different interpretations and different meanings depending on the context. A precordial transition occurs at the point that the QRS complex in the precordial leads changes from an RS morphology, that is small r, large S, like this, to a large R, small s, or simply monophasic R morphology, in which the R to S ratio is equal to or greater than 1, as in lead V4 here. Now, many definitions note the first large R, large S complex in which the R is greater than the S, because the transition so often occurs between leads. Now, I want you to note that the change is from a small r, large S to a large R, small s, not the opposite. The change is going from a predominantly negative morphology to a predominantly positive morphology. Okay, now what does precordial transition represent? First, it represents the rotation of the heart, either clockwise or counterclockwise. For some of you, that would be anti-clockwise. It also represents chamber hypertrophy, usually the right atrium or right ventricle. It often indicates myocardial loss due to previous infarction. And it can also indicate the location of a ventricular ectopic beat or rhythm. Okay, we're going to talk a bit about the rotation of the heart, either clockwise or counterclockwise. Here is a clockwise rotation. The precordial transition really occurs at lead V5 because there is an equiphasic QRS there. The R to S ratio is 1. Some authors, though, prefer the first lead with a QRS in which the size of the R wave is greater than the S wave, which in this example would be lead V6. We were fortunate to have the actual transition point at lead V5. Now, do you notice anything else? Sorry, but I just couldn't help pointing this out. We have symmetrical peaked T waves. We have a first degree AV block. And we have very, very small P waves. This all adds up to hyperkalemia. Here we have an example of a counterclockwise rotation. Okay, on this ECG sample, Where is the precordial transition? If you look in V1, we have a predominantly negative QRS complex. But if you look in V2, we have a predominantly positive QRS complex, so the precordial transition occurred somewhere between leads V1 and V2. There is our precordial transition. Here we have a counterclockwise rotation. This is not infrequent, and it's usually a benign finding. Okay, so where is the transition lead on this ECG? Well, if we look in lead V1, we see a primarily negative QRS complex. But when we look in lead V2, we see a primarily positive QRS complex. So that tells us that the transition point is somewhere in between leads V1 and V2. We call this an early transition. Early transitions can begin from even before lead V1 all the way up to and including lead V3. Now, this is normally a fairly benign finding, and it's often due to either misplacement of chest electrodes. It could be a normal anatomical variation of the heart's position, or electrical orientation, or electrical axis. Counterclockwise rotation, also known as an early transition, is more common in healthy individuals. Now we're going to talk a little bit about how chamber hypertrophy can have an effect on precordial transitions or rotation. Okay, here we have an example of an early precordial transition due to right ventricular hypertrophy. It has nothing to do with the origin of the heartbeats. This is due to right ventricular hypertrophy causing a counterclockwise rotation. Now, hypertrophy sometimes can cause a clockwise rotation, but in this case, it's caused a counterclockwise rotation because the predominantly positive QRS complexes have moved towards the right. This is a counterclockwise rotation. And as you may have suspected, it's due to the fact that we have done an ECG on a small child. Now we're going to talk about the effect of a previous myocardial infarction on precordial transitions and rotation. Let's take a look at this ECG here. A previous inferior MI has caused a left axis deviation with a shift of the precordial transition leftward. Now, sometimes an anterior fascicular block or an inferior MI, both can cause a left axis deviation and a clockwise rotation. Now, we do not have an anterior fascicular block here, simply a left axis deviation, but just plain left axis deviations can cause a clockwise rotation. And we see here that the transition lead appears to be lead V5. Now let's take a look at how the precordial transition can give us a hint as to the location of a ventricular ectopic impulse. Okay, let's take a look at this ECG here. We obviously have a wide complex tachycardia, but we would like a hint as to which ventricle is the source of this ventricular tachycardia. We see right off the bat that we have a late transition. The QRS complex in lead V4 is primarily negative. In lead V5, it's mostly positive. And by the time we get to lead V6, it is a monophasic R wave. So we have a late transition. We also have left bundle branch block morphology in lead V1. Now, most people would say, oh, that proves that this is coming from the right ventricle. Well, when we're dealing with wide complex tachycardias, in some cases, not all, but in some cases, the left bundle branch block morphology could be originating either in the right ventricle or in the left. It's not quite as specific as a right bundle branch block morphology in which case there would be no question the origin of the impulse would be in the left ventricle. Now we can see here that we have an inferior axis. In other words, the impulse is traveling from high to low in the ventricle, and it's coming from the outflow tract area. We also see evidence of AV dissociation here. The blue arrows indicate PACs that are occurring in this rhythm, but we do have AV dissociation. This is definitely a ventricular tachycardia, and in this case, most likely it is a right ventricular outflow tract tachycardia. So the late transition is a big hint that the tachycardia is coming from the right ventricle. Impulses originating in the right ventricle tend to have late transitions. Impulses arising in the left ventricle tend to have early transitions. Now I'm going to talk more specifically about the precordial transitions, early transitions and late transitions. We're going to begin with early precordial transitions. Now, there's something you really need to be aware of about impulses traveling through the heart in regard to precordial transitions. The more myocardium an impulse must travel through, the larger the R wave in the recording lead. Now, the farther away the impulse origin is from the recording electrode, as in this example here, the more myocardium it must travel through, and the larger the R wave in the recording electrode. If an ectopic focus is located in the far posterolateral wall of the left ventricle, then it will appear early. First of all, because it's ectopic, but also it will appear before the normal depolarization from the left side of the septum. So lead V1 will have a QRS with a large, most likely predominant R wave, since it's traveled through more myocardium than usual. Now, as the ectopic focus is moved more and more to the right, it will eventually reach a point where the R wave height equals the S wave depth, the transition point. Now, I don't want you to think that the transition point is always in the wall of the right ventricle. It will usually be somewhere closer to the septum. Now, speaking in general terms, an ectopic impulse that originates in the left ventricle will manifest an early precordial transition, that is, before lead V3. An ectopic impulse that originates in the right ventricle will manifest a late precordial transition at or after lead V3. But, of course, there's a problem you need to be aware of. If the precordial transition is between leads V3 and V4 inclusive, the origin of the impulse could be in the right ventricle or in the left ventricle. If lead V1 manifests a right bundle branch block or a right bundle branch block-like morphology, the origin is definitely in the left ventricle. But if lead V1 manifests a left bundle branch block or a left bundle branch block-like morphology, the origin actually could be in either ventricle. Now, let's review what we just covered. For an early transition, the transition point will be either before V1 or from V1 to just before lead V3. And this is indicative of an impulse origin in the left ventricle. Now, remember, in this case, in this context, we're talking about ventricular ectopic rhythms, which would be either a PVC or ventricular tachycardia. Now, for a late transition, it will appear from V3 through V6, preferably V4 through V6, because that helps us avoid the issue of the precordial transition being between V3 and V4. But a late transition is indicative of an impulse origin in the right ventricle. Now you're probably thinking, what's going on here? How can an impulse be from either ventricle when it looks like it's a left bundle branch block in lead V1? Well, here's what you need to understand about impulse foci, about pacemaker foci. There are often two parts to a pacemaker focus: the pacemaker cells themselves and the exit pathway. Now, the upper part of the right ventricular outflow tract is located directly anterior to the aortic valve area, not the septum. It's located just over the aortic valve area. Now, impulses that arise in the aortic cusps, and many of them do, can exit into the left ventricle or the right ventricle. So it is possible for an impulse that originates in the left ventricle to present as right bundle branch block or left bundle branch block in lead V1. And this is not due to the location of the actual pacemaker cells themselves, but to the exit pathway. Now, you don't need to worry about whether the impulse is arising from the left ventricle or the right ventricle for the most part. 99% of everyone interpreting ECGs needn't worry about the problems associated with precordial transitions between leads V3 and V4. In fact, that's the most common or normal area for the precordial transition in the majority of individuals. And since the vast majority of people do not have dysrhythmia problems related to the outflow tracts, it's usually not an issue. The problem is mainly for the electrophysiologist that's planning an ablation procedure. I want to thank you very much for your time and attention. And I also want to invite you to join me and my 22,000 plus followers twice weekly on LinkedIn for ECG tips and tricks. You can find us at #ECGNerds, or attend one of my classes here in Houston, Texas, or in London, United Kingdom. I teach two classes: the Master Class in Advanced Electrocardiography and the Master Class in Advanced Dysrhythmias. All my classes are live in-person classes lasting 4 days. They're very much like boot camps because we go from 8 o'clock in the morning until 5 in the afternoon. The most inviting thing about the classes I teach, though, is the amount of individual participation. I keep my classes small, and each person participates in the analysis and diagnosis of complex ECGs or complex dysrhythmias during class with my guidance. Now, I want you to feel free to join my new group on LinkedIn, ECG Nerds, and here I've listed my website address as well as my email address if you would like more information. I also want to point out that the next 2 frames following this show information regarding my next upcoming masterclass in advanced electrocardiography, the masterclass in advanced dysrhythmias, private tutoring that I do over the internet, and the fact that I can travel to different parts of the world if there are enough people to justify a class. I've given classes in England, in the Netherlands, in Italy, in Hungary, as well as Canada and Australia. So if you have a group of people who would like to have a class in your country and save on the travel expenses, then give me a call. Again, thank you so very much.